I have nothing to disclose. I'm going to kind of combine two talks. I'm going to talk about complex salvage cases, and I'm going to kind of intertwine some recidivism. And what I would say and preface this talk with is the same things that you look at to take care of limb salvage patients are the very factors that cause recurrence and recalcitrant wounds. So we're kind of looking at what I call the 4 pillars of limb salvage that you really need to hone in on. Now there's multiple factors that have been talked about that are all very important, but these are the most important things in my mind to get these wounds to heal and to hopefully salvage the limb. I would address your attention to this article. This came out from European group. Lipsky is one of the co-authors, and this is a great review article on diabetic foot problems, infections. There's some residents in the room, and I think it's a very good thing to look at. And when we talk about limb salvage challenges, Dr. Carman talked about this, there's just so many aspects and factors that are involved. You need to be cognizant of all these things. And one of the things that I think you need to avoid, we kind of have tunnel vision with respect to wound care. Wound care is absolutely essential, and it helps preserve limbs and save people's limbs. But if we just focus on the wound care and become tunnel visioned, we kind of miss the forest from the trees. And so we have to look at other things that may be persistent factors in causing an ulcer to persist or a wound to persist. And so we're going to look at infection, neuropathy, biomechanics, function, and then revascularization. And this is a 42-year-old insulin-dependent diabetic, type 1 diabetic, that had a pretty significant infection. And for me to sit here and tell you that this is something that I did would be a mistake. I helped take care of this guy, and I converted him from the left-hand screen to the right-hand screen, but there were 12 other individuals involved with this gentleman's care. So you have to make sure you have all your pieces in place in order to take care of these people and get the kind of result that you and the patient want. So here's a case, and I show this because you can kind of do this everywhere. I practiced in Pakistan for the last 6 months of 2014. And here's a gentleman that went on the pilgrimage to Mecca, went to Hajj. It's actually a 40-day process. He came back on October the 5th, 2014, with this. He left with a sub-2 callus, okay? So essentially, he converted a callus to a very severe infection. He was seen by his primary care physician on the day he returned, who was actually a dermatologist, was a friend of the family. He was placed on Keflex. He didn't get better. I saw him about a week later, and I remember these dates because I saw him on my birthday. So otherwise, I wouldn't remember this stuff. So I saw him a week later on my birthday, and this guy was sick. His foot looked terrible. He had subcutaneous crepitation on the top and the bottom of his foot. White count was elevated, glucose elevated. But otherwise, you know, he's hypertensive. He had a cholecystectomy. Didn't have a lot of significant history. But here's his infectious process. And so if you go from the left-hand side to the right-hand side, this is the entire treatment. We debrided this guy 4 times. He had wound care for 2 months after the most recent debridement, and then eventually we converted it into a wound on the top and the bottom that could accept a skin graft. On your far right-hand side was 30 months post-skin graft application. So this example is you have a very significant infection. You have to address the infectious process very aggressively. And as an example, if you look at the second picture from your left and the third picture, it took me forever to go from picture 2 to picture 3, and the reason is the guy had a septic arthritis in his second MPJ, and I didn't realize that until I debrided him the 3rd time. Ended up amputating his toe, and his wound progressed very quickly after that. So you really have to thoroughly investigate these patients with respect to infection and address every aspect of that infection, whether it's a soft tissue process, a joint process, bone, or a combination thereof. You need to have ID on board to get this thing under control. So now we're kind of go, the last patient also had some neuropathy, but we're going to talk about neuropathy a little bit more. This is a gentleman that had this ulcer for about 20 months. And had unbelievable attempts at getting this to heal. He had multiple rounds of antibiotics. 2 or 3 podiatrists saw him, an orthopedist saw him. And so I saw him prior to BKA, and that hole that you see, not only did it probe the bone, I could have taken my fingers and just snatched his medial cuneiform and pulled it out of the wound. So this guy had a significant neuropathy related to a Charcot deformity, and his medial cuneiform was infected. It was osteomyelitic. So he would go through wound care, antibiotics. This would heal, he would stay off of it, and as soon as he walked on it, it would open up again due to the prominent bone and the infection in the bone. So what do? We first have to get the infection under control. So we excise the medial cuneiform. We delayed closure about 5 days later, and we sat on him for about 6 to 8 weeks. Non-weight bearing, antibiotics, local wound care, and we got him converted to what you see on the right-hand side. At that point, now we have to address the deformity, and we have to realign the foot so he doesn't, when he starts to walk again, he doesn't walk on a piece of bone that's out of position. So we did a pretty standard fusion. And this guy was a great patient, but he definitely scored high on the knucklehead scale. And so the bone wasn't great distally, the purchase wasn't great with the screws and plates. I put a frame on him because I knew he was going to walk on it. But we got this guy to where he healed. This is about 8 weeks post-op. And his alignment of his foot's reasonable. It's not a perfectly aligned foot, but it's much better than what we started off with. And so I think in most of these patients that you'll see, it's a combination of things. And the first one, infection, was the most important problem. In this one, the osteomyelitis plus the neuropathy played a part. Now we'll talk about biomechanics, and this is probably my favorite patient that I've taken care of in my career. This guy came in to where I practiced first in Huntington, and I saw him every week. It wasn't my patient, it was one of my partner's patients. Great partner, did everything he could to get this guy to heal, did wound care every week. He wheeled him in a wheelchair, sent him out. And so finally, I saw this guy about, I don't know, probably about 3 years after he initially came to the practice. I was now in an orthopedic group, and this wound had been healed multiple times, and every time they could get it to heal, they put him in an offloading brace of some sort and it would break down again. Well, this is why. He had a fixed ankle valgus deformity, and this is what I'm talking about. You can't be tunnel visioned with the wound. You have to explore as to why the wound continues to recur and why there's such a high rate of recidivism in some patients. And I think this is pretty self-explanatory. This guy had a valgus ankle deformity that was fixed. It was a rigid deformity, and there was some question about osteomyelitis. One of the things that you have to understand when you approach this patient, this looks like it's a pretty simple case. You just pull the foot back into normal alignment by putting some varus, but the problem is the foot's been in this position for such a long time. You have to take the fixation out of the fibula. You have to do a proximal ostectomy on the fibula and then put your frame on, and then you can get your correction and do your ankle fusion. We also took off a large portion of his medial malleolus. There was a question as to whether he had osteomyelitis there or not, and he's getting an ankle fusion anyway with the frame, so we just tried to nip that in the bud and get rid of it at the same time. This was a staged procedure as well. So the last thing, and this is probably the thing that's the most disturbing to me, and I would say that I'm not as good at this as I should be or want to be. And the other thing I would say that's nice about this program, most of the people that are giving you opinions, I call them they're the people that write the articles. So you see Bunty and Shishebor are both at this program. Most of the articles that get cited, the speakers are here, and I think that's a nice thing. You almost get like a peer-reviewed opinion when you hear someone speak. And so they reviewed a database of 20,000 CLI patients, and they found that 54,000 of the patients that had a major lower extremity amputation had no attempt at revascularization 1 year prior. That's a little alarming. But then when you look at this study, this is a Medicare database that was reviewed for a 10-year period of time. Only 68% of the patients had arterial testing prior to the amputation. This study looked at patients for about 24 months prior to the amputation. What's most alarming is this. The arterial testing varied by location of amputation, but it was the worst for foot amputations. And so what I would say to you is a couple of things with respect to arterial revascularization. You have to look at the macrovascular, which is typically our ABI, but you have to start looking at the tissue perfusion, whether that's a TBI or whatever you like to look at to indirectly get you some sort of assessment of tissue perfusion. You need to start doing it because just looking at the vascularity, arterial evaluation on 62.5 patients or 5/8 of the time just isn't going to get it done. So here's a patient, last case, and we'll get out of here. This is a guy that came in. I saw him on March 16th. On the far left, that's March 17th. The second picture, and his white count's elevating. His pain's a little bit out of control. He has diabetes, but the diabetes isn't the huge issue. He's essentially a vasculopath. He's got disease everywhere in his body with respect to arterial blood supply. And so we did an amputation, but prior to doing it, I contacted the endovascular guy that's near me and said, I'm going to be sending you someone. We got his toe off, we got his white count heading in the right direction, got him stabilized. And the reason I put these two pictures on the right are this. The one that's second from your right is prior to the intervention. So that's on March the 19th. The one on the far right is the one done after the intervention. And I think you can see just a difference very quickly in the quality of the wound. There's not as much wound desiccation, there's some granulation tissue, it looks better. And so after that, I had planned to do a TMA on this guy. He came into the office literally yellow. His creatinine was about 2.5, 2.6, and so his kidneys did get hammered a little bit with the intervention. And so he had all kinds of workup. He had his heart looked at. At the end of the day, his EF was less than 15, his creatinine continued to stay elevated, and he had some liver problems. And so we kind of had to manage this guy in a palliative manner. He was absolutely not someone that we could take to surgery. He's certainly not due a TMA. His coags were off the charts. And so we kind of managed him a little by little, and we got everything to heal. But I never got the chance to do his TMA, and I was going to do a gastroc recession with it as well. And this kind of goes back to the biomechanics. So now he's lost his EHL tendon, his tibialis anterior tendon is working harder, pulls his foot into varus. He gets another problem on the lateral side of his foot. And so we kind of have to manage this locally. We did a local procedure. And we ended up taking out his fifth ray and his fifth toe. And as Dr. Botek said, I mean, this foot looks horrible. I would never want this foot. But this guy now, this is about 26 months post initial intervention. He has a foot that he walks around on. He wears a surgical shoe most of the time, but I think that this is a save, and I'm happy with it. We didn't get to do all the stuff we wanted to do, but we kind of applied the principles of infection, neuropathy, biomechanics, and revascularization in this one patient and was able to get a reasonable result. Thank you very much for having me here this weekend, and we'll see you tomorrow.